Welcome, everybody. And as Shelley said, thank you so much for joining us this morning. Today, we have Jen Vendetti. Jen is a social worker and parent educator at UConn Health Parenting and the Mind Over Mood Initiative. Both are programs addressing early relational health and maternal mental health within the early childhood home visiting system. Jen has dedicated her career to maternal child health, perinatal mental health, and starting in attachment research in 1999. She's a co-founder of the Connecticut chapter of Postpartum Support International, where she chairs the board of directors, volunteers as a PSI coordinator, and serves in several committees. She is also on the board of directors of the of the Connecticut Association for Infant Mental Health, where she co-chairs the Promotion and Education Committee. The Department of Mental Health and Addiction Services, as well as the Connecticut Women's Consortium, welcomes Jen and thanks her for presenting to the WSPIC group this morning. Welcome, Jen. And
thank you so much, Sheila.
Take it away.
Thank you. Thank you so much. I'm truly honored to be with you this morning, and it's my great hope that my severe allergies this year do not interfere too much with my presentation. I will do my best. I don't know if we have any other allergy sufferers out there, but I've never had allergies this bad before. Eyes are running, nose is running. It's been real for sure. So we're going to talk this morning together about perinatal mood and anxiety disorders. I want to give you a picture of the Connecticut landscape of treatment and care resources, and I invite you to think about what I'm leaving out, or what you what you see are some of the gaps. And I would say maybe, chat those in about, let's see, I've got until I think about 11. So maybe about 11:15, you could start putting in your thoughts and ideas as I go through some information today. I am going to you're going to see on some of the slides the acronym PMH. So that's going to stand for perinatal mental health. It just makes it a little shorter than PMADs, because perinatal mental health really encompasses the larger array of emotional and psychological changes that all perinatal families are experiencing during pregnancy, birth, and postpartum year at least, right? But perinatal mood and anxiety disorders are conditions, right? So there are a number of symptoms that the birthing person is experiencing that then leads to one of these perinatal mood and anxiety disorders. Okay. Now, during the perinatal period, we know that these disorders really come forth at a much higher prevalence rate than we would see at any other time in the mother's life. Okay. So these disorders, essentially, we're talking about depression, always laced in with anxiety. We see that regardless of what sort of classification or way that we're thinking about these illnesses, we often see perinatal scary thoughts coming forth. There was some incredible fMRI data that was done here in Connecticut, the Yale Child Study Center, and they looked at parents' brains before, mothers and fathers' brains before pregnancy and after pregnancy. And they really did see that there were areas of the brain that were, highlighted, right? They were activated. And those areas of the brain really are the limbic system, where you see more of this protective stance and this fight or flight response. So perinatal scary thoughts are really common at this time as well. For clinicians that are doing diagnostic interviews, using the peripartum onset isn't incredibly useful, because the DSM only gives you a very short period of time to use that onset. But suffice to say that perinatal mood and anxiety disorders primarily are encompassing depression and anxiety with features of these scary thoughts and you will often see the bipolar presentation come forth during the perinatal period as well. So left untreated, these conditions can cause babies to be born underweight, preterm, they interfere with parent-child bonding, and they can lead to substance use and family violence. So we're talking about 1 in 5 women and 1 in 10 men who are experiencing perinatal mood and anxiety disorders. Again, something different than the baby blues that almost all birthing people are going to experience during this time, okay? And we know the baby blues, the culprit there is the hormonal changes, but perinatal mood and anxiety disorders, we're gonna look at the risk, and it's not gonna be surprising to you all. So prevalence rates are 15 to 20% of all women, 40 to 60% of low-income moms. Bob Ammerman and his team have done the most extensive research on moms and home visiting, and they found 29 to 61% of moms. And the pandemic findings, some of you attended the CT-AIM conference on May 12th, and we talked about this. So myself and Maciel did look at literature. It was national literature. And across the board from the Canadian studies and the US studies, looking at 33 to 36% of families affected. Some of those papers were not diagnostic, they were self-report, but definitely there were impacts for our pandemic parents for sure around mood and anxiety changes, okay? Perinatal mental health conditions are caused by changes in biology, right? Physiology, psychology, and of course the environment, right? So the risk factors, the number one risk factor is going to be if I have a personal or family history of depression or anxiety, okay? And this is concerning to all of us because we know that our young people are suffering greatly, right? We're seeing increased anxiety in our adolescents, and our adolescents will then move into a reproductive stage. And so they're coming into this perinatal period with a lived history of anxiety or depression, okay? So we always want to be thinking preventatively. Lack of social support, particularly from their partner. And we know that there's comorbidity between IPV and perinatal mood and anxiety disorders. Experience of traumatic birth or previous trauma. And everyone here in this meeting is aware of the impact of trauma on a family's development and functioning. And also families who have baby in the NICU. I'm going to play this 1-minute video, and some of you had the pleasure to see this video on May 12th. I think it's so impactful. I know you won't mind seeing it again because it really sets the stage for what we're talking about, pressure, the pressure on our perinatal families. So we have about 100 babies born each day here in Connecticut, and we can estimate that about 7,200 families a year here in our state are affected by perinatal mental health complications, okay? So I thank you all for being so passionate about supporting families. Let's see what happens if I play it right from there. It's pretty good. Let me know if you can't hear.
Pressure pushing down on me, pressing down on you.
I want it to be big. Here it is. Okay, start again.
Pressure pushing down on me, pressing down on you. No cure is for under pressure. that brings a building down, splits a family in two, puts people on the streets. Hey there, hey there. Pressure pushing down on me. Pressure.
It's always important that we bring ourselves in the present moment and the present time and thinking about really some of the very significant complications that can be happening during this time. What do moms say? How do they express themselves? They say having a baby was a mistake. I'm no good at this. Many moms report, and this is one of the hallmark symptoms of perinatal mood and anxiety disorder, is mothers feeling disconnected from their baby. So their emotional state is numbed and they're really struggling to get that, that inner drive, that emotional experience. So they may be doing everything that needs to be done to physically care for the baby, but the serve and return process is lacking that emotional experience. That's what we're really going for, right? We want birthing people to have a drive, right? To be playful and to get to know and to build relationship with babies. And that's really hard to do when you're experiencing depression, anxiety, and of course, any of the other PMADs. I'm afraid to be alone with my baby. Okay, sometimes you'll see that with families that you're working with where, the mom is really very happy when there's other people around that can help her with the baby because she's scared to be alone. She's scared to bathe the baby. If she's experiencing OCD during the perinatal period, she could have worries about walking downstairs with her baby, bathing her baby, because she may have fantasies about harming the baby. But we know, especially when mothers are reporting these types of scary thoughts and they are recognizing or they're saying, I don't know why I'm thinking this way, and I'm scared that I'm thinking this way, that they are not at risk for harm to their babies, okay? Very different than a mother who is unaware that these thoughts are not okay, right? She's exhausted, she's overwhelmed, and she says she can't sleep even when her baby is sleeping. So that's a great question to ask moms to kind of get a little insight if you're not using a formal screen or you just want to have a relationship-based conversation. How is your sleep? Even when your baby is sleeping, what happens for you? Okay, so then we can tap in and we can do some psychoeducation on self-care. I'm such a bad mother. My baby would be better off without me. 55% of babies living below the federal poverty level are raised by mothers with depression. Low-income moms are less likely to receive treatment. 2/3 of severely depressed moms, this is Veriker's findings, moms of 9-month-olds were not receiving treatment. And that's why we're all here, because we're in this work to do everything we can to provide support, treatment, and care to our perinatal families. Only 15 to 25% of suffering mothers receive some level of care. Okay, so that's the work that we want to do here in Connecticut to change that statistic. Moms living in poverty, women of color are more likely to experience perinatal mental health conditions and are less likely to get help. Why? Because of lack of access to healthcare, including culturally appropriate mental health care. That's changing, and I'm happy about that. Cultural and racial biases in the healthcare system. And I know many of you have been involved in racial disparities in maternal mortality and morbidity in Connecticut. That's really important work that is directly related to the perinatal mental health experience of families. There's more barriers to care, and there's fear, a lot of fear around child welfare referral or immigration referral. I want to say a couple words about postpartum psychosis, because I'm going to be talking about some of the gaps that we're seeing in Connecticut in terms of treatment. And I think this is one of the perinatal mood and anxiety disorder conditions that concerns us, okay? Because this is a psychiatric emergency, and because myself, over the past couple of years, I've been aware of moms who have been hospitalized for postpartum psychosis. In 2 of those cases, there were family members from out of state who just really called anyone they could find to try to get help for their mom, sister here in Connecticut. And they reached me, they reached other people. And in both of those cases, we were able to tap into the Connecticut Office of Early Childhood for postpartum doula services. And why that's so important is because you all know so many families are isolated from their families of origin, either because they don't have any family here in the state or even in the country. And so if a mom is hospitalized for a perinatal mood and anxiety disorder, what's happening at home with a baby who is a few days or a few weeks old, okay? In both of these cases, there was dad, but dad alone was not able to do all the caretaking. And often fathers don't have even the few weeks that mothers have for paternity leave. And so we were able to tap into that, but it's very concerning, right? Because it's an emergency all around. So we're concerned not only about the mom and getting her access to hospitalization, but also thinking about the baby and the birthing partner and what's happening and what we can do to support the whole family through this process. So this is a rare condition. But as Teresa Toomey says, that's not the same thing as saying that it never happens, okay? So we want to be aware. And Teresa Toomey, in fact, who wrote Understanding Postpartum Psychosis, a Temporary Madness, is a lawyer and a woman with lived experience. She has been a staunch advocate for treatment and care for postpartum psychosis through PSI for years. And she's right here in Connecticut. This is a really fantastic book for any of you who are not perinatal at this time, okay? So we're talking about 1 to 2 in about 1,000 moms, okay? 50% of moms that develop brief psychotic disorder during this time, and it can occur in pregnancy, but mostly we see postpartum. 50% have a history of mental illness, and primarily the risk factor is going to be bipolar mood disorder diagnosis, okay? So we want to be very thoughtful in putting in our whole treatment and care team around a mom who has a diagnosis or is being now diagnosed during the perinatal period with bipolar mood disorder diagnosis, okay? And again, the kinds of thoughts, the kinds of fantasies, the kinds of behavior that you're going to see with this, again, very rare condition, is going to look very different from a mom who may, again, have some perinatal scary thoughts, because with postpartum psychosis, I'm not aware that these thoughts And these images that are coming into my brain really are irrational and they don't make sense. So it's typically going to be people around me. Oftentimes, these symptoms are going to come forth at the time of delivery or in the few days or first couple of weeks postpartum. So who's going to notice? Partners, nurses in labor and delivery and maternity, pediatricians, okay? But we have to be prepared as a state to be able to respond to moms who are in psychiatric crisis, okay? There are some tragic outcomes that can occur with postpartum psychosis, and those are suicide and infanticide. Postpartum PTSD. So Dr. Cheryl Beck, right here at the University of Connecticut in the School of Nursing, she is one of the premier researchers in birth trauma and postpartum PTSD. Her findings are 9%. Those are women who will qualify for PTSD diagnosis based on a birth trauma, but she's found up to 34% of moms experience a traumatic birth. And in the pandemic literature, we are seeing higher rates. And I can attest anecdotally for the women who got to me or one of the other volunteer PSI coordinators during the pandemic, we heard about a lot of birth trauma, okay, more so than we were in the past. Anecdotal, okay, but it's something that we need to really consider and take very seriously. And I'm really hopeful for the future of doula services in the state of Connecticut. And I know some of you are working on that with Doulas for Connecticut Coalition, and I thank you so much for that great work. It's really important. Suicide and overdose are leading causes of death in the first year postpartum. Okay, so that's what we're all here working toward preventing and providing an experience, a parenthood experience for our families in Connecticut that feels good, is safe, is fulfilling, right? I share with you here Mother Noise. Cindy House is also a Connecticut author and has written this book. I just started it, okay? But Cindy talks in her memoir about lived experience with addiction and motherhood. And she's coming at her memoir from this experience of now having parented her son, and he's 9, and she's trying to figure out how she's going to tell him about her lived experience with addiction. So I think that's a really important book. I saw it at the Bristol Library, so I know it's at the Bristol Library, but I had it sent over to my library, so I got it through the library. So it is out there. Yeah, hopefully we're coming out to the other side. But the pandemic impacts were real, and many of you are working with early childhood families who were what we would call pandemic parents, right? And what was their experience in relationship to perinatal mental health, right? Well, they had fewer in-person visits. Hope After Loss in their research found on average, we'll have in a non-high risk pregnancy about 13 in-person visits, but that went down to about 4. Limited birth support, of course. It did change, especially after the vaccination phase of the pandemic. Doulas were then able to come in, but it was very limited in the beginning. There was no childbirth education at the shutdown phase of the pandemic, no maternity tours. And so all of the normalizing behaviors that are available and normalizing experiences that pregnant people can have really didn't exist. And postpartum as well, right? So there weren't in-person support groups or even in-person breastfeeding consultation, right? There were travel restrictions, infection and prevention protocols, and that, of course, greatly limited the ability for even local families, extended family, to come and visit the perinatal family. So our isolated families were even more isolated, right? We saw in the literature increased rates of depression, anxiety, stillbirth, very concerning phenomenon during the pandemic, significant increase in stillbirth and birth trauma. We didn't have home visiting in the beginning, right? We didn't have early intervention in person, right? We immediately, so many programs, and I'm sure you all had this experience in your programs, you immediately went to a virtual platform, and that was really beautiful. And I think that was just a wonderful response of programs. But again, that was different, right? Than having in-person time with our families. And the work of the Peace Study Group out of Massachusetts, they're a large research team, and they have done some extensive work. I mean, they've got probably 10 different studies going on looking at effects of the pandemic. And they did find maternal depression and grief symptoms interfered with baby bonding. And again, at the time that we're coming home and starting to establish a biorhythm with our baby, it's really important that we create an emotional experience for bonding. And that's a concern, right? When we're thinking about both perinatal mental health as well as infant mental health. We saw increased substance use among parents. There's several papers on that. And we had also 2 very tragic deaths by substance use of little ones, toddlers, right? And that was published in the OCA's annual report. So we had some really significant tragic events happening during the pandemic. Telehealth psychotherapy only. We're going to talk a little bit more about that. It's changing, but slowly, okay, but slowly. And less treatment resources were available to families. Okay, so this is just released. It's a maternal mental health report card. We're going to talk about this for a minute, okay? So the Policy Center for Maternal Mental Health used to be called 2020 Mom. They've been around since about 2013-ish. And they've been working closely with a number of powerhouse groups. California's Maternal Mental Health Now, the Maternal Mental Health Leadership Alliance, PSI. So this is like, like we can take this pretty seriously because it's a think tank. It's an important group. But let's see where we're falling here in this report card. And we can kind of think about whether we agree with the grade that Connecticut is getting. So in this slide that you see, I just have a picture of it, but we're going to go to the report card, okay? So let's just take a peek. I'm not liking what I'm seeing already, right? So here we are in this dark purple, and then New Hampshire's also dark purple, and then dark purple seems to be the color for some of these Midwestern states, and I don't know about y'all, but, we kind of say, hey, we got a lot of things going on here in the Northeast, right? And especially around reproductive health and so forth. So like, hey, what's going on there? They say here that the national grade was a D. Okay. And that only one state managed to exceed a C+. So right there, we know that their standard is high, and it should be. It should be, because we do have a lot of work to do. 42 states received Ds and Fs. Okay, so I guess we're not alone if we had a poor grade, right? Let me go back to my Connecticut. Here we go. Okay, so we got an F. We got an F, you guys. Okay, we're going to talk about this. Why did we get an F? Okay, so these are the metrics that they use, and they have a few statistics about Connecticut here. Annual birth rate, 35,367. We all know that that's gone down, but that's an accurate figure. They say we have a provider shortage gap. They say we only have 46 certified providers. They're talking about the PMHC, certification in perinatal mental health, which is still a new certification. So, I don't think that we should necessarily expect that we'd have lots and lots of providers with that certification, but it tells us that they feel that that's important, that that's really demonstrating that providers, are really specialized in this area. They say our provider ratio is 2.26. I'm not exactly sure what that means. Maybe that there's for every 2 moms, there's 1 provider. I'm not sure. If any of you wants to take a guess, let me know. And then caseload, I don't know if that's psychotherapy or psychiatry. And licensed prescribers, they're probably talking there about reproductive psychiatry. I don't know if Dr. Foray is on this call today, but I think that she would agree with me that other than herself, and just a couple of other psychiatrists would classify themselves as a reproductive psychiatrist. So that's really a provider area that we do need to see growth in here in Connecticut. So they were looking at providers and programs, screening and screening reimbursement, and insurance coverage and treatment payment. Okay, we got 3 awards. We got an award for private insurance postpartum screening billing. We got an award for Medicaid expansion. That's awesome. And for postpartum Medicaid expansion. Yeah, we know we have that, and it's great. And so, but we got a lot of marks off. Okay, so let's talk about that a little bit more. How is Connecticut doing in response to perinatal mental health? So I just took those 3 categories: providers and programs, screening and screening reimbursement, and insurance coverage and payment. And here's where you can help me. So I am going to offer for you to use the chat on this, because I want you to tell me, what do you think is missing here? So from my perspective, when we think about providers and programs, we have the Hartford Hospital Peripartum Mood Disorders Program in Connecticut. Okay, that is a perinatal specialized outpatient treatment program, primarily medication treatment, okay, serving mothers who are pregnant and postpartum first year with a hard stop. If the baby is 13 months, no. So pregnancy, postpartum. How is it specialized? So it's specialized because the psychiatric nurses, Sarah Amenta, the psychiatrist, Katrina Weiss, Elizabeth Birch, there's a couple of others. They have had training in reproductive psychiatry, in addressing perinatal mood and anxiety disorders, and treating perinatal mood and anxiety disorders with medications that are safe and effective when a woman is pregnant or when she's breastfeeding, i.e. postpartum. Okay, that's what makes it specialized. And I'd actually have to talk to them more about how often the baby is invited to session, but I'm going to assume that because it's perinatal specialized, that probably is the case. Especially if a mom says, I wouldn't have childcare to come, they would say, oh, of course, bring your baby. So that's important, right? But it's outpatient. Okay, so my symptoms have to largely be managed, right, outside of the treatment space. Okay. They have had psychotherapy availability from time to time, but they're struggling right now with filling a clinician position for this program. Okay. They're struggling to find a clinician for this program. But you can call, and they have a beautiful website and brochure, and you can call, and they're booking out, they'll try to get moms in within a couple of weeks, 3 at most. It's an important program, right? Because it's specialized. Okay. And there are still many prescribers that feel uncomfortable prescribing during pregnancy and breastfeeding. Okay. Independent practice psychotherapy. This is a workforce that I've been working with since 2015. It is a workforce that has a lot of experience with agency-based practice, home-based practice. Many independent practice psychotherapists came out of ICAPS, FBR, other types of clinical home visiting, child first, etc. And they're now in private practice. Okay. So it's a growing workforce. And when PSI signature training came to Connecticut in 2015 and 2018, there were quite a few independent practice psychotherapists there. So it's a workforce that's been pretty dedicated to this population. And it's a workforce that probably, at least in my opinion, has the most expertise in addressing perinatal mood and anxiety disorders. And I should also say that when we're talking about the whole broad lens of perinatal mental health, we have to be thinking not only about these mood and anxiety disorders, but about the pregnancy experience, the birth experience, and perinatal loss. Okay, for sure. Child First was homegrown here in Connecticut, Bridgeport Hospital. And Dr. Lowell built that program as a clinical home-based program. And all of the Child First clinicians have child parent psychotherapy training, but most, if not all, have done the PSI training and other trainings around perinatal mood and anxiety disorders. So they do try to address clinically those disorders. And if the relationship work, if they just don't have time to address individual level symptoms, they will refer typically to independent practice, and they'll continue their work on the relationship. We now have our own psychiatric consultation line here in Connecticut. So that's a big win for Connecticut. We have Access Mental Health for moms, and it's really important to get the word out to providers on Access Mental Health for Moms, as well as the Mother to Baby program, which can also support providers in that sort of risk-benefit analysis of medications during pregnancy and postpartum. But Access Mental Health for Moms really, at least in my mind, I think of as a treatment program because it's a complement, an adjunct to treatment that's being provided to the mom using reproductive psychiatry expertise that we have in Connecticut. But we've got to keep building on that too. We have home visiting. It's not universal, but in home visiting, all of the home visitors are screening, and they're all referring in to us in Mind Over Mood. And we then connect those moms that are suffering, sometimes dads as well, sometimes couples therapy, to clinical services. And then we have an array of DEMIS women's service programs in Connecticut. And the one that I've been familiar with was the program in Young Adult Services, peripartum specialized program, a wraparound service program. So, I don't know that we couldn't get the D, we've got some good things happening, right? Screening and screening reimbursement. I can't speak too much to screening reimbursement. I know early on DSS always reimbursed screening that was done under Husky, so I don't think that's an issue at all. And it gave us a check mark under commercial insurance reimbursement for screening. So I think that's okay. In terms of systems that are screening, Connecticut WIC has been working on their screening and addressing maternal mental health for a number of years now. And so they are screening universally. And of course, home visiting is as well. Insurance coverage, we now have our non-citizen perinatal moms Husky insurance plan, and that's been a real blessing for us in Mind Over Mood, because we've always maintained a very small clinical service in Mind Over Mood, and that's for our moms who have no insurance and no pathway for insurance. But now that's changing, which is really great, because then we're able to access a community-based provider who could stay with the mom longer, because our clinical service is really small in Mind Over Mood. So how are we doing? Well, I'm going to show you another slide that has some service array, and you're going to see there's a box that's outside of the circle. Okay, we want all the programs in the circle. And I want you to think about, well, you know, she doesn't have this up here, which is one of the ways that Connecticut is responding to perinatal mental health. So tell me if you think I'm missing something here. So treatment and support for perinatal families looks like this. Psychotherapy is going to be our first line of treatment. It's a very effective treatment for any of the PMADs, with the exception of brief psychotic disorder, which of course needs to be managed in a hospital. And again, the largest workforce that we have that's perinatal specialized. You're going to see those who have a PMHC. I have a PMHC. You can see that here as an allied professional, okay, because I'm not a clinician. But most of the PMHCs in Connecticut are clinicians, and most of them are in a private practice or a group practice. Okay, support groups. If you came to the CTAIM conference, you heard me talk about support groups. You know, I'm a support group. I'm a group work social worker, and I do parent education in groups. And I believe that families belong in groups, and that really helps with the transition and building self-efficacy. But perinatal mental health support groups, you know, we really only have a handful in Connecticut. Only a few have gone back to in-person. That's a real need. I had 2 calls last week. Okay. These are calls that come into the PSI helpline, either a text or a call. And then I get an iCarol alert in my email that says somebody wants to connect with me. So if the mom calls, I'm going to say mom because the majority are moms, reaches out to the helpline, the national PSI helpline, says she's from Connecticut, she's going to get to one of 10 or 11 coordinators in the state. We're volunteers. Most folks that are involved with PSI, especially the coordinators, have lived experience. So in a way, our peer support. Sometimes you'll have a clinician that wants to also volunteer, but it's a separate role than her clinical role. So 2 calls come in. I have a mom in Manchester. She's having a lot of anxiety with borderline panic attacks, getting ready to transition back to work. And this is all text. I always say to the moms, I'd love to talk to you by phone. I would love that. But a lot of our moms, they want to do text. So that's okay. So we're texting, but I don't totally know what's going on. So I'm just sort of, you know, and I say, what would help her to transition back to work, to feel some type of grounding in this, you know, motherhood experience while she's now integrating this other role and, you know, has to address, you know, the economic strains of family life and so forth. So I say, any chance you and your baby could go to a support group tomorrow, because there happens to be an in-person group in Manchester, and it happened to be happening the next day. The Brave Space, it's called. And she writes back, yes. I'm like, okay. Send her the details. I tell her, I'm going to text you tomorrow in the afternoon. She texts me at like 12 and says, I feel so much better. What the heck happened? What was the magic that happened in the support group that she felt so much better, right? This is a mom who reached out to the National Helpline. Okay, so she was not feeling so good. So support groups are powerful. Had another mom, she got to another in-person group, Marie Russell's group at Waterford Library, and she also had a great experience. However, that mom wants psychotherapy, and guess what? She has a $40 copay per session. So we'll get there. We need more breastfeeding in-person groups, and Hope After Loss is definitely taking the lead on perinatal loss groups, but the groups right now are virtual. And again, I think we need experiences for families. Parent-child interaction groups, those are going to come in the form, the largest entity running play groups across the state are going to be our FRCs, Family Resource Centers, and we can look up if we're thinking about a family who can get out and access a group, especially our mid-infants, like our 6-month and late infants, or 10 months into toddlerhood. That's where we want to be thinking FRCs, although some may also welcome the younger babies. Infant massage groups, we run them routinely here at UConn Health Parenting, but they really are like finding a needle in a haystack. So I would love to see more people trained in infant massage and operating those groups. I'd love to see them across libraries and everywhere where birthing people can access them. Infant massage groups are great because they're not just mother-based as maybe a breastfeeding group would be. Birthing people, grandparents are going to all be welcome in the infant massage group. We talked a little bit about medication therapy. Again, perinatal specialized medication therapy is going to be Hartford Hospital peripartum program. But psychiatry down here, it says psychiatry and psychiatric nursing. Private practice, psychiatric nurses are coming on the scene, and many of them are receiving training in perinatal mood and anxiety disorders, and that's exciting. Our home-based programs for psychoeducation, as well as supporting PMH in many ways, home visiting, doula services, childbirth education. But what's not in the circle? If anybody wants to challenge me on specialized acute treatment programs specific to pregnant and postpartum women in the first year, I invite you to do so, because they don't exist in Connecticut. If a woman needs day treatment, she needs to go to Rhode Island. If she needs inpatient and wants her baby to join her, there are only 3 of those programs in the United States. Okay, so a program that, a hospital-based program like an IOP, a PHP, an inpatient unit that's perinatal, right? It's got a lens of pregnancy, birth, all the providers are specialized. There's an attention to lactation, there's an attention to the environment. All of the patients or clients, if you will, are also mothers going through this experience. The groups are going to have a lens of, looking at all of those different risk factors that we talked about. There's going to be attention to birth trauma, right? All of that. And for the baby to be part of that work, when possible. We don't have it. Okay. And so when we start to think about some of our, again, mostly we're talking about depression and anxiety, and mostly it can be managed with psychotherapy and some with psychotherapy and medication. But we do see some higher levels of depression. We do see comorbid PMH, right, with substance use disorder. And we see our brief psychotic disorder, right? It's rare, but that's not the same as saying that it never happens. So how are we prepared? It's not to say that our moms who have had a psychiatric emergency have not been well treated. I'm not saying that at all, because I've heard some very positive stories, good treatment in our hospitals here in Connecticut that have inpatient psychiatric units. But you could just close your eyes and imagine the difference that it would make if the program was perinatal focused for that mother. Okay. I've had many more calls this year than ever before from doulas, home visitors asking me about where is the nearest perinatal IOP? I'm like, say what? We have some fantastic nonprofit organizations here in Connecticut. Again, I go back to the grade of F. I'm sort of arguing against that here, right? Because I'm saying, hey, we do have a lot of good things here in Connecticut. We have March of Dimes Connecticut, CT-WIC, home visiting, PSI. We were the first chapter. We were the first chapter of PSI. So hello, doesn't that say something? We got to get some credit there. Hope After Loss, Tiny Miracles Foundation, bedside support in like 6 hospitals. Incredible organization out of Fairfield County. But they're in Yale now, so they're not just Fairfield County. They're doing incredible work with their peer mentors. Mother to Baby. Mother to Baby would be happy to come and talk with you all anytime. Statewide, free. Otis is their parent organization. That's the Office of Teratology Information Specialists. So like, these people are they're so smart. They know all the stuff. So Mother to Baby is the specialized arm of Otis that just focuses in on pregnancy and breastfeeding. That's it. That's their time. That's their frame. And they broker all of the research on any type of teratogen, or like, as I call it, thing that I put in my body that I want to know, is that harmful? Is that harmful? And so they do consultation on anything other than herbs. They don't do herbals, but they have like insane fact sheets, Zoloft in pregnancy, marijuana and breastfeeding. They have it. It's great. Really cool organization. And they're here at UConn Health. They're upstairs. Quelf, they're taking the lead on all of our maternal policies. And I know there are others, but these are the ones that come to mind that we use a lot as PSI coordinators. In terms of the PMH specialized treatment workforce, again, we have independent practice psychotherapy. There is now a PSI directory. So if you're like, well, how do I even find these people? There's a couple of ways. There isn't just a one-stop shop, I'm sorry to say. I do use a couple of directories. When I started to work with this workforce, I started out with the Behavioral Health Partnership, talking with them about, they have sort of a whole list of specializations that if you become a new Husky behavioral health provider, right, your behavioral health provider and you're paneled with Husky, they say, hey, tell us about your practice. And the clinician will say, yeah, I specialize in this, I specialize in that. But there wasn't a way to categorize around perinatal mental health. So what we did at the time, this was 2012, we did a survey. We wanted to know who was out there treating PMADs. And we just used women's services because that's all there was at that time as a behavioral health partnership category. But then they changed it. And I gave some feedback on the name, and it's in there, Perinatal Mental Health. So if you're someone who uses the Behavioral Health Partnership Directory, which is really easy to use, you can use Perinatal Mental Health category. PSI now has a directory. It's still growing though. So I don't only use the PSI directory, but it's pretty good. And then, I still use Psych Today. And then I use the category pregnancy, birth, postpartum. In Mind Over Mood, we form partnerships with these practices so that if I get a referral, I'm not like cold calling therapists to say, hey, tell me about your practice. Do you have openings? Blah, blah, blah. You telehealth, what are you doing? I already know ahead of time, but I'm always looking for those practices because they're really important. Child First is perinatal specialized. Hartford Hospital, Access Mental Health for Moms. Middlesex Behavioral Health Outpatient. I put a little star there. They're just getting going. I don't know where they're at yet, but they were going to do a peripartum outpatient program. So again, you're going to be changing your environment. You're going to be thinking about the mom from the pregnancy, birth, lactation, bonding perspective. You might have group program there. So I'm not sure where they're going to go with it, but I know it's happening. Child and Family Agency of Southeastern Connecticut, Jenna Cohen. She has a model. This is a small program, but she has a model of perinatal specialized psychotherapy treatment, and then a psychiatric nurse who will do intake and attend to moms where medication is a good idea. Are there others?
Jen, excuse me, there's some
Yes.
comments in the chat. I just wanted to make sure you were able to.
Let's stop and chat. Let's chat. Let me look at the chat. Okay. Oh yeah, thanks. Okay, Teresa's book. Okay. Hey, hi, Stephanie. Yeah. Yeah, Stephanie, that's such a good question. I don't know where that will come from. Like, I really don't know where that will come from. That's an excellent question. What we saw in the legislature, we saw Senate Republicans who put a bill forth. I didn't follow along because I don't have time, but now PSI Connecticut has a committee, a policy and advocacy committee, and they did follow several bills this year, and they did do some testimony. But that bill, it was called like the Perinatal Mood and Anxiety Disorders Bill. And I talked to them a couple years ago, and they were wanted background and so forth, and their thing was about mandating hospitals to provide education to birthing people. And I even said to the staffer, when I got to talk to the staffer, again, this is like a couple years ago, I said, okay, so here's the thing. I told him the biggest barrier that we have to treatment and care for perinatal mood and anxiety disorders is, wait for it, commercial insurance. Okay. And specialized acute treatment. Like, we've got some major barriers. Okay. If you're Husky insured, I'm like happy as a clam with that referral, because all the providers I know are paneled with Husky. There are so many of our families who are commercially insured with, and you'll see it on a slide, co-insurance, $4,000 deductibles, and $40, copay each session. That's a problem. So to just tell the hospital, hey, we're going to make sure that you tell patients about these issues, you have to make sure you're setting those hospitals up for success. And you have to put money in to give them all the resources and training and support that they need to then be able to do this mandated education. So that's the only bill I saw. So from like the legislature, other than that, I think it would come from the institution itself. When psychiatry grand rounds at my hospital had Dr. Conte from Mass General. So Mass General not only has a huge research arm dedicated to perinatal mental health, and they have clinical programs. And I said to Dr. Conte, how did you get funding for your clinical arm, your hospital programming? And she said, we got it through research. We had to start with research because when I don't totally understand it, Stephanie, but I guess it has to do with you can build the program, but there's no way you'll be able to keep it alive with just the reimbursement from insurance from the client, the mom, let's say, right? Like you just wouldn't be able to afford it. So you need somebody within that hospital system who is like going to make it happen and has the power to keep it going. And then I think you need either, a grant, partnership with a state agency, something. I haven't heard, and even Hartford, like I said, I'm in communication with Hartford and they're trying to find a clinician and they can't find a 40-hour clinician to take that job.
Yeah,
So
I figured it wasn't an easy question, but I had
it's
a
a really, really important question because, years ago, I'd be like, what is wrong with me? Like, am I just really not that smart? Like, I don't understand, and so now I can sort of, I don't want to accept it, but I guess I kind of understand a little bit more. And when you look at I'll show you what's out there nationally. And even like California, who's been, they were on this for way before anybody else. And they only have like 3 or 4 programs. And that's a huge state. So, but you need like women and infants in Rhode Island, they have that champion and they have that, that academic side and they have the clinical, capacity and they made it happen. But I'm assuming you've got to get grants and you got to keep getting grants. Yeah. Because you can't fund it only on the reimbursement from insurance, unfortunately. Yeah.
Thank you, Jen. Jessica had a comment and then Daleen has a question.
Oh, great. I see Jess. Substance use treatment. Yes, that's right. So, probably some of you in this meeting could tell me more about our response in Connecticut to SUD among women and how we, can intersect that with a perinatal lens, right? Because not all women with substance use disorder are perinatal. But certainly we have women's services programs. And some of them are acute treatment programs, which is beautiful. And I guess I would just say, let's put a perinatal lens on and see how we're doing and then evaluate it that way, right? So that would be all of the staff are trained in perinatal mood and anxiety disorders, have understanding of birth trauma and birth trauma sequelae. Definitely, I know all the programs have a trauma lens. I know that's fantastic. Lactation should be addressed. And I know it's hard because some of our moms with substance use disorder are not currently parenting their child. And that makes it really, really complicated. Makes it really complicated. What does that look like and feel like? Some moms are, some moms are not. If the babies are invited to the session, some moms are separated from their babies, other moms have their babies. That's really, that's really hard. But there are models out there, and that's what I would say. I would say any program that's going to start, look at the models out there. Talk to those other states. I mean, if we were going to start day treatment in Connecticut and we didn't go to women and infants, that would not make any sense. Look at the models. Yeah. Yeah, and I guess I would also say, Jessica, that I do think that there is a need. So if we're just thinking about the private practice psychotherapy workforce, how many of those perinatal specialized clinicians also have a background in treating substance use disorders, right? Because we might say, oh boy, now we just took a big pool of people and we whittled it down really small. And that's a problem, right? How many of the perinatal mental health support groups are out there are specific to women in recovery? None that I know of. So I hear what you're saying, Jessica. That's very important. Yeah, it's a specialization within a specialization. Yeah, who'd I miss? Dalian. Hi, Dalian.
Good morning. I just wanted another or a clarification on something, and I apologize if you said this. With mental health being one of the largest, a very common reason why people are dying during or after delivery. I'm understanding from your previous slide that suicide is the most common one, and that how that is done is by overdose. What are the other two leading causes or ways in which people are actually doing this?
How are women committing suicide, or
Yes.
or looking at all of the causes of death? So when we're looking at causes of death around perinatal, of course, we're looking at pregnancy-related death, right? So those are our heart conditions, our preeclampsia, right? Mothers who died during childbirth. But yes, suicide and substance use, overdose. So, I'm more familiar with the moms who have committed postpartum suicide who did not have a substance use disorder. And I'll give you an example. When we first started, at least like creating a strategic plan in Connecticut, we started at the Women's Consortium, and the year was 2014. And just 2 days before that conference, it was a training, and then we met after to create like a strategic plan, like what would we want to see in Connecticut. And of course, at that time, it had to do with just getting training here in Connecticut. But a mom had jumped. She committed postpartum suicide in New York City, Cynthia Walkenheim, and she jumped out of her Brooklyn. It was 8 stories. Her baby was a little baby boy. He was completely unscathed. He is grown up, doing beautifully. Moms, when it comes to postpartum suicide, moms will many times take the child with them. And it's a phenomenon. I mean, there's people out there who study just this phenomenon, because it has to do with this pathology of like, I need to be the mother for my child and I can't. And it's like the ultimate form of protection. I'm going to see if I can, maybe I could send it to you, Dalian. So PSI has a quilt that they developed, and each square on the quilt represents a family who committed postpartum suicide. And they had one quilt. We've had it here in Connecticut. That quilt has come and has toured. When Hartford Hospital started their program, we brought the quilt there. Unfortunately, there's 2 quilts. There's a red quilt and there's a blue quilt. We've had both in Connecticut. When the quilts travel, the book travels with the quilt, and you can read the stories. So I can't say this is, always what happens, because every story is unique. But essentially, the conditions that moms are experiencing are very severe depression, and just are not being, the treatment, if they're receiving treatment, isn't working, right? We saw that with Lindsay Clancy. She was on medication, she was being treated, and yet she still committed infanticide. Her psychiatric illness took over, right?
Okay, so it sounds like I'm hearing you say there's the taking of the overdose, but in some cases people are actually jumping and people are finding other ways to
Oh,
commit suicide.
yes.
Okay, just was curious what maybe those
And
top
it's a
3 ways were.
small, relatively speaking, it's a small population, but when you look at overall, what were the reasons why moms died? And I think the Maternal Mortality Review Committee here in Connecticut has found that as well, that mental health issues, substance use disorder was related in some way to, the death. But basically what we're saying is, when you look at all of the causes of death of the woman during pregnancy or the first year postpartum, suicide is part of it. Overdose is part of it. Bleeding out is part of it, right? So it's a phenomenon, and it's something that, keeps all of us up at night, worrying about the mom that, isn't being treated or isn't being treated, again, not to say from the treatment side, like they're not doing their job, but just saying that whatever treatment they're experiencing, it's not working.
Now, this
It's not
discussion
working.
is helpful because how they say, I believe there was data that said that men oftentimes, when committing suicide would like use a gun or something like that. So of course,
That's right.
in a home of a person who, if it was a male, we would say, okay, a gun in a home is something that is an extremely high risk situation, to look out for that as something, as a potential issue or something to guard against that may, be a way in which this person may take their life. So thank you. I just wanted to get an idea of what those other things were. So now, of course, say as a support person, one of the things that might be important for someone to look out for in this case would be if there's excessive pills lying around in the home, which could potentially lead to an overdose, or, if there were any other things that a caregiver, it would be important for them to know, knowing that resources aren't in abundance in the way that we would want to, helping to inform the person in addition to support person, I thought would be perhaps a good way to consider how to mitigate some of these situations, and knowing what maybe some of the common ways that is happening, I thought might be helpful. So thank you.
Yeah, I would love to actually, I'm going to put that on my list. I'd love to follow up with that for myself to really have a better understanding. Many of us come into this work during, our time when we're in early motherhood, right? I trained as a doula 19 years ago, and I was pregnant with my first child, right? So it's tough, right? Because again, you shouldn't be reading this during that time, and your kids are little, so I haven't gone into all of the, sort of the nuances of what happens. But I'll tell you that in one of the film screenings around PMH, Dark Side of the Full Moon, which we actually screened at the Women's Consortium a number of years ago, there's a mom who attempts suicide. She talks about what she, like how she was feeling. I honestly believe, if we want to look at common factors, I honestly believe the best thing we can do as the support people, I think isolation is the biggest enemy that we have. I really, really do. We have to fight against isolation. We have to trust gut feelings, especially those that are doing, home-based work, nursing, you're on the phone, it just doesn't sound right. What can we do? And just really trying to kind of listen in. Hopelessness, right? What are the risk factors? So actually, you'll see reports will tell you we don't know enough about postpartum suicide. We really don't. We do know that some of the risk factors and some of the studies have found history of hospitalization for mental illness, significant trauma history, sexual abuse, significant physical abuse as a child. Those are risk factors. Yeah, those are risk factors. But I will say too, I think we have something that is helpful. Before I get into recommendations, I'm going to go to it. If you go on to the postpartum.net website, there's a place where you can find intensive treatment in the US. Here again are the inpatient perinatal psychiatry programs, and we do have New York. I thought that was just a women's only inpatient, but maybe it's changed. And maybe the babies now can also join in. I'm not 100% sure, but it's listed as a perinatal psych. Oops, sorry. Hold on. Let me go back. Hey, there we go. I won't click on the link just because of time, but obviously we're not there. You know, we're not listed here. California, Florida, you know, but there's not a ton though. I do know moms who have left the state to seek treatment in North Carolina. And I definitely know moms that have left the state to seek treatment in Rhode Island, for sure. But this is what I want to share. This is what I want to share with you. So HRSA launched the first ever National Maternal Mental Health Hotline on Mother's Day last year. Congress authorized this maternal mental health hotline, and they did so in the Consolidated Appropriations Act of 2021. This hotline service is 24/7, 365 days a year, provides free, confidential, emotional support, information, and referrals to any pregnant and postpartum mothers facing mental health challenges and their loved ones. Professional counselors, okay, staff the hotline. So the counselors are actually PSI staff that staff this HRSA hotline. They provide support in English and Spanish via voice and text so people can get the help that they need. There's interpreter services available in 60 additional languages and a relay service for people who are deaf or hard of hearing. The hotline is available 24/7, and it is staffed by professional counselors. However, it's not a crisis line. So a hotline counselor is going to do a warm transfer over to 988 if a mom is in real-time crisis. Okay. They will also do a warm line transfer to the National Domestic Violence Hotline and the Disaster Distress Hotline when needed. If an individual is in immediate crisis, like imminent danger, they should call 911, etc. So I think this is important. What I did actually just really recently, when you go onto the site, you can get, and HRSA's always had this, where you can get materials, free materials for your programs. But now they have a whole new toolkit because of the hotline, which is really good stuff. And I just ordered my stuff yesterday. So of course they limit it, you know, but if you need more, just ask your coworker to also submit and get those materials from HRSA. This hotline is intended to prevent the tragedies that we're worried about. That's what it's intended for. But I will say, I mean, they get lots of different kinds of calls. And during the formula shortage, That was like their number one call. So PSI has always had a helpline. And a helpline is different, right? A helpline is a place you can text or call, and someone's going to get back to you in a 24-hour period. And as I said, people go to the helpline in English and Spanish. And if they're in Connecticut, the helpline volunteer will connect them to one of us in Connecticut. So that's a safety net, but we're all volunteer. So it worries me a little bit when I see, lots of safety nets being relegated to all volunteer, hope after loss, tiny miracles, PSI. I think we have to be mindful of that. But it's wonderful to have that safety net. It really is. And mostly what we're doing is we're connecting moms to psychotherapy and support group. But again, as we're saying, we need more clinicians who are also trained in substance use disorder. We need more clinicians also trained in birth trauma, because we're seeing a lot of that too. Also trained in perinatal loss, because we're seeing a lot of need for individual level psychotherapy to address perinatal loss, stillbirth. And it's a super specialization, if you will. We still need it. So I really do invite you to visit postpartum.net, because you're going to be like, oh my gosh, what is all this? There's so much there. The first thing that happens when you click get help, it's going to drop down and you're going to see all of the free services for families in English on the left and all of the free services available in Spanish on the right. And that could be anything from fact sheets or information to the free online support groups happening every week, like 30 to 35 free online. They're national. So if one of our Connecticut moms wants to attend, she may or not be, she may be the only one there from Connecticut. So it's different, right, than walking into a support group here in Connecticut with other people from your region. It's going to feel a little bit different, but in a way that can be really nice. Some moms really like that, that they can go and sort of be anonymous, but they're free. And there's a number of, oh my goodness, there's a number of specialized support groups. They now do have a birth trauma support group. They do have, I believe they have they have a specialized coordinator for women who are experiencing perinatal mental health complications and are in recovery or struggling with substance use or misuse or disorder. Climb Out of the Darkness, that's our community event that is done every year, usually around the solstice. We have events happening throughout Connecticut in June. And those are really fun. There is a fundraising component, but I never talk about that with families, that I just want to come to the event. But it's usually a walk. It says a climb, but only if you do it with Lisa Candles is it actually a climb. She really makes you climb, but mostly it's a stroller-friendly walk. There is a PSI directory now. These are links. I'm going to send you this slideshow as a PDF, and Sheila can send it out to you all, and you can play with the links. Connecticut also has a website that's part of the national Our Parent organization, but then we also have a website here in Connecticut that we built because we were the first chapter, and PSI didn't know a lot about how to support chapters at that time. So we did a lot of stuff ourselves. PSI has a psychiatry consultation line, and here are the support coordinators here. I just want to give you a flavor. Oh, whoops, sorry. I'll have to check that link. Some of the activities at the chapter level, PSI is a membership organization, so we have chapter membership at $20 a year, or you can be a member of PSI National, which automatically makes you a member of whatever state whatever state you live in. And almost every state has a chapter now. So we do a monthly newsletter. Anybody can sign up for that. It's right on our homepage. Just put in your email and you'll get our monthly newsletters. We've been doing lunch and learn events. We have an annual member event celebration. We're doing book talks. We're going to have Jessica Cuomo, who lives in Guilford, and she wrote about her experience with postpartum anxiety and OCD. We do have a scholarship program. Our scholarships right now are for clinicians, so treatment providers who identify as Black, Indigenous, or a person of color. We have a Providers of Color collective that meets quarterly to talk about perinatal mental health for Black and Brown women, our climb, member mingle, et cetera, et cetera. So it's a cool group, but it's all volunteer. We do the best we can. We try to follow up. We do get lots of requests for different activities. What we're really trying to do right now is we have a free presentation. It's an hour, or it can be an hour and a half if OBs or midwives have that time. And we have been struggling greatly to get into practices. We've only done like one talk for grand rounds, but we really want to just get in with OBs and midwives because they are on the front lines. We were working on, PSI has a training called Components of Care that I think anybody who's working in the perinatal space needs to have. And I think we need support from our state agencies, other, grants, because we've brought Components of Care to Connecticut 2015, 2018. But 130 to 150 people attended. We need to have that every other year. And we're going to need funding because it can be expensive. I mean, it's not an expensive training. I don't mean that, but just it can be expensive for an individual, doulas, parent educators, independent practice people. So it's great if a state agency can support that. I'm going to go back for a minute and then I'm going to close this out. I know my hard stop was 11:10. Okay. There might be a better way to do this. Sorry, guys. It's close by. I know it. It's right here. Here we go. Okay. Just to wrap up some of what we've talked about, I think we do need a biannual. New York does this, so they have the Components of Care training, but PSI also has a frontline provider training, which is for OBs, primary care, family physicians, psychiatric nurses, psychiatrists. We had it all lined up, you guys. It was going to be a Gateway. We had a contract with Gateway. It was going to happen June of 2020. And then the pandemic hit and it fell apart. So that's also a training I would love to bring to Connecticut because I do think, the OBs are screening and prescribing more. They really are on the front lines. And that's why mental health access for moms is so important because they're out there and they are prescribing now much more than they ever were before, but they need training and support. We need acute level mental health specialized treatment. We need to arm our emergency departments and OBs with resources. There's no question, because emergency departments are struggling when they have moms come in. They're really struggling, I think. I told you the biggest barrier to treatment and care, at least for psychotherapy treatment, it's insurance. It's commercial insurance. Don't get me started. Most people don't receive any childbirth education. They say only about 30% of first-time parents receive childbirth education. But I wonder if we use the mantra, if you build it, they will come. We've had a successful prenatal parenting program here for over 12 years. And people all across the state want to get into it. But that would turn it into something different than what we want it to be, which is a group program. So we don't want hundreds of people in our class, right? That doesn't work for anybody. But why do they come? Because we're talking about topics beyond stages of labor and because it's free. Every hospital has to provide free childbirth education. We have to make doulas more accessible. And I would love to increase support groups. Any of you on who are policy people, just tuck this in the back of your mind. PSI has a program called Mind the Gap, and they have a whole consulting firm that works with any state that wants to engage in Mind the Gap. And it takes, PSI and, it could be March Dives, could be Demas, could be anybody who wants to partner up and go through this process. So it's a process of creating state level meetings for the purposes of, maybe Stephanie, it depends on what the group decides. It's supposed to be a group decision-making process, but they take you through, and you sort of through the process figure out, well, what does Connecticut need most? If you're in Texas, you're like, oh, well, we need Medicaid. Yeah, we're way beyond that here. Like, we can move past that. We can go to something else and say, what we need in Connecticut is this. And then you bring all these people to the table. So it's a whole thing that we can do. I will stop the share because I think we got to almost every slide, and one of them had a question like, what can we be thinking about? What can we do? And I think you'll all be thinking about that, after today, and you've probably been thinking about it before today. But I hope it was helpful to frame out, a little bit about the way I see the landscape in Connecticut, and, maybe where we need to go.